Hi everyone! Good day, this is Dr. Von and welcome for another discussion sa ating Clinical Chemistry 2, your environmental carcinogens, toxins, and acute poisons. I believe this will be our second to the last topic discussion ng ating CC2 lectures, and I guess our last topic will be your drugs of abuse. So before that, I would really apologize for the delay of the posting of my video lecture because I really tried my best na ma-post siya as soon as possible. Kaya lang, the face-to-face classes is very tiring. You know what, no? Hindi lang kayo ang napapagod. Every time that umuwi na ako sa bahay, as in, automatically nakakatulog na lang talaga ako. This is very tiring but very, very fun. So shout out sa ko ang second o third cycle dira. Section yun? EFGH and IJKL. I really had fun and I hope you just hindi lang kayo nang ka-learn but you really also had fun with the face-to-face classes. As in, super fun. Okay. I'm very sorry I cannot open my camera because I feel so stressed and tired. So, audio na lang. So, unang-una nating i-discuss will be your environmental carcinogens. So, first, what will be our learning objectives for today? To identify the different environmental carcinogens. So this is a very, very boring topic. All you have to do is just enumerate those environmental carcinogens and then identify what will be its detrimental effect to the human body. Again, this is a very short discussion. If you read your your clinical Henry, siguro isang paragraph lang itong environmental carcinogen. So, please read your book. And then, to understand the basic pharmacology principle. Before I will proceed with the discussion sa ating toxins and acute poisons, it would really be beneficial on your part to have at least an idea of your pharmacology, basic pharmacology. Because on my time sa amin sa curriculum namin na MLS dati, we still have pharmacology subject. As in, literal na subject siya. Kasabayan niya ng CC2, kasabayan ng bacteriology, mycology. Meron kaming basic pharmacology at our time. And I don't understand bakit kaya tinanggal ang pharmacology sa inyong curriculum. I really don't understand because I believe it would be very beneficial na to understand basic pharmacology, yung mga basic drugs and all. Even though that we're not pharmacists, at least we will have an idea kahit sa basic principle man lang. Kaya nga, I'll try my best to incorporate somehow the basic pharmacology principle. And then, to know the different toxins and poisons and its detrimental effects to the body. Next is to learn the basic treatment or management of these different toxic substances. So, how do we manage our patient if we encountered this type of patients where they were able to acquire these different toxins or poisons? At least the basic management so that you will have an idea on that matter. Okay? Let's start first with your environmental carcinogens. Number 1, we have your benzpyrene. So your benzpyrene, ano kaya itong benzpyrene na to? This is actually tingnan nyo sa diagram, polycyclic aromatic hydrocarbon in complete combustion of your organic material or organic matter found in your coal tar, yung tobacco natin, and your grilled meat. Again, this is an aromatic compound produced in your cigarettes and also present in your exhaust of engines. That is why, this is the reason why nagkakaroon tayo ng lung cancer. Kasi nga, present siya sa ating cigarettes. And remember, what type of cancer would be present? Remember your cancers, you will have different forms of your lung cancer. For those, for male patient, usually, ang type ng epithelial type ng cancer is usually a squamous cell for a male. And for those with strong predilection with smoking, small cell carcinoma. Again, for those male patient with a strong predilection with your smoking, usually ang type ng lung cancer nila is a small cell carcinoma. And again, would it be possible for a patient with lung cancer without smoking? Yes, that is still possible. Yung mga, tawag niyan, yung mga second-hand smokers. So, the type of carcinoma that is usually present is an adenocarcinoma. So, please remember that. Small cell carcinoma for strong predilection with smoking. And for female who never smoke, type is your adenocarcinoma. Okay? We also have your nitrites. Again, your nitrites is readily present in a preservatives in your red meats. That's why these are very common, causing colon cancer. So bakit kaya nilalagay natin yung nitrites in our food? Because basically your nitrites will prevent bacterial growth. That's why nagkakaroon, we can see a red or pink color in meat, and there is a salty flavor that is actually brought about by the preservative nitrites. Okay? We also have your aflatoxin. I guess you're familiar with your aflatoxin. You're brought about by your Aspergillus species. This is very prominent in causing hepatocellular carcinoma, no? Commonly sa mga naga-molds na nga to ang mga tawag nito, peanuts, and as well as in your corns. Again, your flavus and your parasiticus causing your corn, peanuts, tree nuts na aflatoxin. We also have your aromatic hydrocarbons. We have your benzene and your ionizing radiation. These are very prominent in causing your acute leukemias. Again, take note, benzene. We have a case, dati medtech pa ako, we have a case of a patient who came in because of parang weakness, and then parang may anemia siya and all. So the patient went and came in sa aming OPD sa laboratory and tested for CBC. And when I checked the CBC sa automated machine, it was very high. It was more than 20. And then because of that, diba, remember, if there's an abnormal result in your automation, you have to check it or to confirm it using a manual count. So we do a peripheral blood smear or smearing of it, and then when we check it, oh my God, you will be very amazed because it was flooded with immature WBC. So most probably, this is brought about by acute leukemia. So we asked the patient to have a checkup, really a checkup. And again, the patient was really requested for PBS to be checked by a pathologist. No? History ng patient, usually nagakuan daw siya guys ng sa mga insecticides, meron silang manggahan. And then, usually, siya rin yung nagsispray nito without proper wearing of anything to protect her from these mga toxic substances. That's why you have to be very careful, no, of using these different insecticides, mga tawag nito, ginagamit for parang fertilizers and all, because we do not know that these chemicals will really cause some detrimental effect to our body. So please take note on that. We also have your vinyl chloride and your thorotrast dye. So your vinyl chloride, usually found sa ating mga PVCs. This is a radioactive thorium dioxide used as a contrast agent until the 1950s. Usually ginagamit ito siya for radioactive for contrast agent. For example, this part here. So pwede siyang present sa PVC or ginagamit siya as contrast agent. So the purpose of having a contrast agent is for possible diagnosis. But then again, this will lead to angiosarcoma. Your angiosarcoma is a rare cancer that develops in the inner lining of your blood vessels or your endothelial cells and lymph vessels. Your angiosarcoma is actually a very fast-growing cancer, very invasive cancer. That's why most of the time or most cases, the patient will have really a very poor prognosis. So please take note on that, vinyl chloride and your thorotrast dye. We also have your asbestos. Your asbestos is a natural fire retardant. Kaya usually nakikita natin to sa mga firefighters. And this is very prominent in causing your lung cancer and your mesothelioma. Your mesothelioma is a cancer of your mesothelium, which is a membrane that lines the inside of the body's cavity, such as your abdomen or your chest. So basically, your mesothelioma is just a membrane. So this is very prominent in causing your lung cancer. Please take note on this. And then we have your carcinogens will bind. So how does how do we detect or test for your presence of your carcinogens in the body, we use your GCMS, which is the method of choice. This is for detection of most unmodified carcinogens. The method is currently your GCMS or tinatawag natin na gas chromatography mass spectrophotometry. Okay, spectrometry, sorry. Gas chromatography mass spectrometry. So, this is the method of choice for the detection of unmodified carcinogens. The question is, how does your carcinogens lead to detrimental effect to the body? So, your carcinogen will simply bind to the DNA, and then it will lead to the mutation in the genetic code. Because of this mutation of the genetic code, this will lead into the formation of oncogene-encoded proteins or oncoproteins, so cancer proteins. That's why this will cause now a detrimental effect or carcinogenic effect to our body. So please take note on that. So I guess that ends our environmental carcinogen parts. Very short discussion lang talaga siya kasi dati nga, sa last time na tinuro ko ito, environmental carcinogen lang talaga yung tinuro ko. And then, I mean, I'm very shocked kasi less than 10 minutes lang and tapos na kami. But right now, they already incorporated your toxins and acute poisons as part of the discussion. So let's proceed before we go to the toxins and acute poisons. Let's proceed first with the basic principles of pharmacology. So ito talaga ang gusto ko ma-learn ninyo by heart. Kasi nga, wala kayong pharmacology na subject, at least you have an idea about pharmacology. Kaya dito nyo masasabi na, ay, buti na lang, hindi ako na-pharmacist. Yeah, I really don't like pharmacology too because there are so many things to remember. Even though, more of principle lang naman talaga ang pharmacology, that you have to understand the principle. But still, there are so many things to remember, most especially yung mga drugs, anong mechanism of action, side effects, pag may patient kami na ganito, ano ang dapat ibigay, ano ang hindi pwedeng ibigay sa kanya. So, there are so many things to remember about your pharmacology. That's why, saludong-saludo talaga ako sa mga pharmacists, no? Tapos ginasaway lang silang tindera, oh my God, if they know lang kung gaano kahirap ang pharmacology. So, again, as part of my discussion sa ating pharmacology, we will have to differentiate what is pharmacodynamics versus pharmacokinetics. So I will have a clue on that for us to differentiate the two, pharmacodynamics and pharmacokinetics. This is the two most important principles of your pharmacology. So first, let's talk about your drugs. When we say drugs, that is any substance that brings about a change in the biologic function through its chemical action. So again, drug, clue word natin, there's a change in the biologic function through its chemical action because your drugs will simply attach to the specific receptors and will cause a certain reaction. And those action is yung ating gustong mangyari sa ating patient. For example, the patient has fever. Of course, we all know that this is brought about by producing a certain substance. That's why nagkakaroon tayo ng fever. And because we don't want that substance to be produced kasi nagkakaroon ng fever ang patient, then we have a specific drug. We give your paracetamol and will attach to a specific receptor, causing it to stop the production of that substance. Therefore, we will able to get a reaction. And that action is what we want for our patient. So basically, drugs will cause a change. When we say pharmacodynamics, this is the actions of the drug on the body. Pharmacodynamics, again, when we say pharmacodynamics, action of the drugs on the body. It includes the receptor interactions, dose response phenomena, mechanisms of therapeutic and toxic action. So we will discuss this one by one later. When we say pharmacokinetics, actions of the body on the drug, this is more of concerned on your ADME, absorption, distribution, metabolism, elimination. Again, pharmacodynamics, action ng drug patungo sa body. Ano ang effect ng drug sa ating body? Yung pharmacokinetics is action ng ating body to the drug. So, how do I remember this one? Ganito lang ang mnemonics ko. Drug, on the body, drug on the body. Pharmacokinetic, akong body on the drug. So, ganyan lang akong mnemonics. Pero baka makonfuse kayo na may ako dito, ako din dito. Pero but remember the word die. Die is drugs, okay? Action of the drug on the body, akong body on the drug. So, please remember that. When you say the word pharmaco, akong body towards the drug. What is the effect of my body, or what is the action of my body on the drug, and concerned about your ADME, absorption, distribution, metabolism, or your elimination. Okay? Pharmacokinetics, action ng aking body on the drug. So again, remember the word ADME, absorption, distribution, metabolism, elimination, and your pharmacodynamics, action of the drug on the body. Then we will be talking about interaction, drug dose response phenomenon, and mechanisms of therapeutic and toxic action. Okay, so first we will talk about your pharmacokinetic. Ano gani ang pharmacokinetic? Ako, my body on the drugs. Action of my body towards the drug. So again, we will be talking about your ADME, absorption, distribution, metabolism, elimination. First part is your absorption. So basically, absorption is the transfer of the drug from its site of administration to the bloodstream, affected by three major factors: route of administration, blood flow, and your concentration. So why does this affect? Route of administration. Paano ba natin binibigay yung drugs? Orally ba? Or by intravenous? Or inhalation ba? Because this different route will affect now our absorption of your drugs. How about the blood flow? If there is an increased blood flow there, then most probably there will be increased absorption. How about the concentration? If there is a greater concentration, then most probably there will be more absorption, right? So again, depends on the route of administration. If we give it on a specific route, then specific route will have a specific absorption. For example, intravenous, is there an absorption there? Okay lang, i-discuss natin yan mamaya. So first route of administration will be your oral route. First, offers maximum convenience. Diba? Usually, binibigay lang natin yung drugs, tinitake lang natin orally, iniinom lang natin. This is the most common route of drug administration. Absorption is very slow and less complete. Again, absorption is very slow and less complete. Bakit? Because of the first pass effect and the presence of your gastric contents. When we say first pass effect, there is a significant amount of drug is metabolized in the gut wall and portal circulation. Again, there is a significant amount of drug that is metabolized. You metabolize now the drug before being used by the body, na may metabolize na siya. That's why there will be absorption is slow and very less complete because of the first pass effect. Next, we have your intravenous route. Your intravenous route is via IV. Again, orally by mouth. Intravenous, dito ini-inject natin. So, intravenous, instantaneous and complete absorption that bypasses the first pass effect. Remember, if tinitake natin orally, remember sa gastric area, there is a first pass effect. But intravenous, we give it directly to the blood vessel. That's why there is 100% bioavailability. Ni-inject na natin agad-agad, hindi na dadaan sa first pass effect. Again, potentially more dangerous because, for example, if you give bigger doses, then most probably that will be very problematic to our patient. That's why you have to control the amount of dose. Because more dangerous siya kasi nga 100% bioavailability. High blood levels reach on a rapid administration and difficult to reverse your effects. That's why you have to really control the amount of drugs that you are going to give in your patient. Next, intramuscular route. Absorption is faster and more complete than oral. Higher bioavailability bypasses your first pass effect. So again, hindi naman to dumadaan sa gastric and gastric, right? Unlike your oral route, dadaan sila sa ating gut wall. Okay? Subcutaneous route, slower absorption than your intramuscular route. No blood vessels in your subcutaneous space. Therefore, large volume doses are less feasible. It will still bypasses now your first pass effect. Again, take note, anticoagulants do not cause your hematomas when administered via this route. So please take note of this one. Again, when you talk about your subcutaneous, just below your skin, slower absorption than your intramuscular route. So sino mas faster? Intramuscular or subcutaneous? It's still now your intramuscular. Again, sino ang mas complete compared to oral? It's gonna be your intramuscular complete to your oral. Buccal and your sublingual route. You have your buccal and your sublingual route. Buccal, pouch between the gums and the cheek. Sublingual, under the tongue. There is a direct absorption into the systemic venous circulation. Still, bypasses the first pass effect. You know the sublingual? Ilalim ng ating dila. Napapansin nyo anong nasa ilalim ng ating dila. So, kindly check. Punta ka sa mirror now. Check nyo anong nasa ilalim ng ating dila. Sige, I'll give you 5 seconds. Sige na, check nyo. Tamad man niyo. Tamad man sila, oy. Alam ko na, hindi ko man i-check. Bahala kayo, hindi ko sabihin. Joke lang. Again, if you check your tongue, what's under your tongue? Ang daming blood vessel. Napapansin nyo? Sa ilalim ng dila, masyadong maraming blood vessel. Kaya nga, there will be direct absorption into the systemic venous circulation. It will bypasses now your first pass effect still. How about your rectal route? There is partial absorbance of the first pass effect. Again, not totally avoided, but partial avoidance. And this is useful for large amount of drugs with unpleasant taste and for patients who are vomiting. So, rectal route. Inhalational route offers delivery closest to the target in respiratory diseases. There is rapid absorption with minimal systemic effects. Again, convenient for drugs that are gases at room temperature, your nitrous oxide and nitric oxide, or easily volatilized na mga anesthetics. So, you give that via inhalational route. We also have your topical route, application to the skin, mucous membrane of the eye, ear, nose, throat, airway, or even for your vagina for local effect. Again, absorption varies with the area of application and drug formulation. Slowest route of your drug administration. Again, please take note of this one. Slowest route of drug administration. We have your transdermal route, application to the skin for systemic effect. Absorption, of course, very slow, but bypasses your first pass effect. So please take note on this one. Again, these are the different methods, no? Or routes of administration, orally, pwede intramuscularly, intravenously, very inhaled, nasally, cutaneously, or via ointment. Okay? So again, tapos na tayo sa first part ng pharmacokinetic, yung ating administration. The second part will be your distribution. Your distribution, this is the process wherein drugs reversibly leaves the bloodstream and enters now the target organ. Again, ina-absorb natin kanina, then ngayon is pupunta na sila sa target organ. Process wherein the drug will leave now the bloodstream. Kasi nga, di ba, ang purpose ng absorption natin, papapasok natin ang ating mga gamot patungo sa ating bloodstream. Now, sa distribution naman, leaves the bloodstream and it will now enters now the target organ. Depends on 4 major factors. We have the size of the organ, the blood flow, solubility, and protein binding. We will discuss this principle, major factors, one by one. Again, your non-ionized, non-polar drugs are more lipid soluble and undergo more extensive distribution. Please take note on this one. A non-ionized, non-polar drugs are more lipid soluble. Since lipid soluble sila, they will undergo more extensive distribution. Bakit kaya? Remember, your cell membrane is lipid containing, di ba? Lipid component siya. So therefore, if it's more lipid-soluble ang drugs natin, it will easily enter our cell. That's why, again, take note, non-ionized, non-polar drugs are more lipid-soluble and undergo more extensive distribution. Okay? Next. Uy, wala pala discuss dito. Sorry. Okay. What's the reason of your distribution? Size of the organ, distribution, blood flow, solubility, protein binding. So, paano natin ma-explain na to? Ano kaya ang reason behind this one? The size of the organ. Again, the size of the organ. The bigger the organ, the more extensive ang kanyang blood vessel, right? So therefore, if the organ is larger, and therefore, if the organ is more larger, more blood vessels, so therefore, more drugs will enter the organ. Take note of that. Blood flow, mas mataas ang blood flow, therefore, again, mas mataas ang blood flow, therefore, more blood flow, more drugs na dadaan, so therefore, more distribution. How about your solubility? Solubility, pag non-ionized siya and non-polar, therefore, more lipid-soluble, therefore, more extensive ang distribution. Protein binding, once yung drug naka-attach sa protein, mas na-distribute ba siya? Yes or no? Yes or no? Again, since naka-attach sa protein, therefore, hindi na siya makaka-attach sa ating receptor. Therefore, protein binding will lead to decreased distribution of your drugs. So, please take note of that. Again, size of the organ, mas malaki ang organ natin, mas extensive ang kanyang blood vessel. So, therefore, same pa rin, mataas din ang blood flow. So, therefore, more distribution. Solubility, non-ionized, non-polar, therefore, more extensive distribution. Protein binding, hindi siya nadidistribute ng mabuti. Protein binding, hindi siya masyadong na-distribute ng mabuti if it is ionized and polar. If it is non-ionized and non-polar, more extensive distribution. How about your metabolism? So we're done. We're done with your absorption and your distribution. Now, let's proceed with your metabolism. Your metabolism, drugs are chemically altered in the body. Your drugs may undergo 3 metabolic phases. This termination of the drug action, drugs are metabolized into biologically inactive derivatives. Conversion to a metabolite is a form of elimination. So you are trying to convert your drugs or metabolize your drugs so that it can be eliminated, so that you can form a metabolite and it could be eliminated. Drug activation, prodrugs are metabolized in the body to become active. Some drugs are metabolically active but still have active metabolites. Elimination without metabolism, some drugs are not modified by the body and will still continue to act until they are excreted. Again, please take note of this. When we say metabolism, drugs may undergo 3 metabolic phases: termination ng drug action, drug activation, and elimination without metabolism. We have 2 phases of your metabolism. So please take note of this. Phase 1, the goal is to convert the drugs to be water-soluble. Again, the goal is to convert the drugs to become water-soluble. Yet, some drugs are still active. So therefore, phase 2, the goal now is to make the drug more water-soluble and inactive. So again, phase 1, convert drug to water-soluble, but still some drugs are active. Phase 2, the goal is to make the drug more water-soluble and inactive. Kasi nga, once it is more water-soluble, therefore, it is easily eliminated in the body. But again, if it's more lipid, pag more lipid ang ating drugs, it can easily be distributed in our body. Diba yung discuss natin kanina? Next, we have your elimination. Your elimination is the termination now of your drug action. Again, excretion, the release of drugs and their metabolites in the urine, stool, bile, exhaled air, etc. And duration of drugs action is determined by dose administered, rate of elimination following the last dose. So, I want you to remember these two important types of elimination. We have your first order elimination and zero order elimination, saturable, or your Michaelis-Menten kinetics. When I say first order elimination, the rate of elimination of the drug is proportionate to the concentration. Meaning to say, kung anong drugs, kung gaano kadami ang na-eliminate, it's actually equivalent. Concentration decreases exponentially over the time. Characteristics half-life of elimination. Concentration decreases by 50% for every half-life, and this is the most common type of elimination. Again, half-life, 50% of every for every half-life, 50%. Tingnan natin sa diagram ito. First elimination, half-life. We are talking about half-life. So again, clue word natin yan ha. When you hear the word first order elimination, think about your half-life. So 5 units per hour elimination rate, 5 units, half-life niya 2.5. Half-life niya again 1.25. Then half-life niyan, divide by 2, divide by 2, divide by 2. So first order elimination, and take note, it will not reach 0. Please take note of that. Liliit lang ng value, but it will never reach 0. Hindi siya magta-touch dito, kasi nga, paliit lang ng paliit, but it will never touch this part here. It will never become 0. Please take note on that. So, your drugs will have different elimination. Magdedepende yan. First, or for example, the half-life of your this drug is only every 2 hours. So, every 2 hours, mababawasan siya ng half kasi nga half-life siya. Then, may ibang drugs na babawasan every 4 hours, every 5 hours. So, magdedepende yan sa ating drug. So, again, first order elimination, that is your half-life. Your zero-order elimination, saturable or Michaelis-Menten kinetics, the rate of elimination is constant regardless of concentration. Concentration decreases linearly over time and occurs when drugs have saturated their elimination mechanism. Okay, for example, this one, 2.5 units per hour is being eliminated, and another hour, 2.5 units, and another hour, 2.5 units. So, every hour, nababawasan tayo ng 2.5, 2.5, 2.5. So, again, there is a constant concentration. There is constant, it is constant regardless of your concentration. So, 2.5 talaga ang nababawas. Dito, is just the half-life. You divide it ng 2. So, 5 divided by 2, 2.5. 2.5 divided by 2, 1.25. 1.25 divided by 2, blah, 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 blah. Kaya nga siya tinatawag na zero order kasi it will reach to a point that it will become 0. Bakit? For example, meron kang 10 mg drugs and ang kanyang elimination is every 2.5 units ang na-eliminate every hour. So, 10 minus 2.5, after 1 hour, nagiging 7.5. After 1 hour again, nagiging 5. After 3 hours, nagiging 2.5. And lastly, after 4 hours, nagiging 0 na siya. Kaya nga, nagiging zero order. It will reach a zero order, 0. Again, first order, half-life, zero order, constant amount yung nawawala. Okay, let's proceed with your quantile dose response curve. When we talk about quantile dose response curve, again, we are already in your pharmacodynamics, so we're done with your pharmacokinetics. Pharmacokinetics, ako to the drugs. Effect of my body on the drugs. Pharmacodynamic effects of the drugs on the body. So, drugs on the body. So, first principle under your pharmacodynamic is your quantile dose response curve. This is the minimum dose required to produce a specified response that is determined in each member of a population. Your quantile dose response curve, fraction of the population that responds at each dose against the logarithm of the dose being administered. Okay, we have your median effect or ED50, median toxic effect which is your T50, and median lethal doses derived. Again, iba-iba ang definition yan. Again, we have your median effective ED50, median toxic TD50, and median lethal dose or LD dose that is being arrived. Therapeutic dose, toxic effect, and your lethal effect. But please take note of these different terms. Median effective, median toxic, and median lethal. Again, when we say median effective dose, it's actually the dose at which 50% of individual will exhibit a specified quantile effect. Again, median effective is the dose at which 50% of individual will have a specific quantile effect. When I say median toxic dose on the other hand, I'm so sorry, this part here, ito, is your median effective. So please take note on that, median effective. Your median toxic dose, this one, kaya nga median because we are talking about the dose required to produce a defined toxic effect 50% of the subject. That is now your median toxic dose. When I say median lethal dose, that is now the dose required to kill 50% of the subject. Not just the toxic effect, but already killed the person. So, lethal dose na talaga. Again, median effective, 50% of individual will have a specified quantile effect or the effect that we want our patient to have. Median toxic, 50% of the subject will have a toxic effect. Lethal dose, 50% of the subject will be killed. Therapeutic index now is the ratio of your toxic dose to your toxic dose to your effective dose. A parameter now which will reflect the selectivity of a drug to elicit desired effect rather than toxicity. Again, your therapeutic index now is the ratio of your effective dose, median effective dose to the median toxic dose to your median effective dose. This is now a parameter which will reflect the selectivity of the drug to elicit a desired effect rather than toxicity. Now, let's define your efficacy versus your potency. When I say efficacy, maximal efficacy or Emax, maximal effect an agonist can produce if the dose is taken to a very high levels. Again, determined mainly by the nature of the receptor and its associated effector system. When I say potency, denotes the amount of drugs needed to produce a given effect, determined mainly by the affinity of the receptor of the drug. So again, when we say efficacy, meaning to say, the maximal effect that the drugs can produce. Maximum. Take note. Think of the effect. Gaano kadami ang kanyang effect na marireach niya. Okay? Potency is that denotes the amount of drug needed to produce a given effect. So, for example, A, B, and C, we give the same amount of drug. For example, we have given the same amount of drug, 100 milligrams per DL. Your A, your B, and your C at 100 milligrams per level will have the same efficacy. So, question here, sino ang mas mataas ng efficacy, A, B, or C? Again, when we say efficacy, the maximum amount they can produce. Take note, at 100, they can reach now, for example, at 10 milligrams per DL, na-reach nila ito both si A, B, and si C. So, sino ang mas effective? A, B, or C? Has higher efficacy? The same. Tingnan nyo, at 10 milligram, for example, 10 milligram, na-reach nila ang level na ito. Na-reach nila ang level na ito. So, therefore, we can say that your A, your B, and C have the same efficacy. But the question is, sino ang mas potent? Sino ang mas potent? Si A, si B, or si C? Again, sino ang mas potent? Si A, si B, or si C? Sorry. My example is wrong. sorry. Again, for example, ganito ha, isipin natin, when you talk, erase everything. When I say efficacy gani, you talk about the maximum effect na pwede niyang maibigay. Okay? When I say potency, the amount of drug needed to produce a given effect. So, for example, For example, ibang-ibang dose sila. Binigay natin si A at a 5 mg dose, binigay natin si B at a 10 mg dose, binigay natin si C at 15 mg. 5, 10, 15. Yun yung dose na binigay natin. Again ha, si A, nagbigay tayo ng 5 mg, si B, 10 mg, si C, 15 mg. This time, check natin, sino ang mas effective? Si A, sino ang may highest efficacy? Si A, si B, or si C? Given the different doses. Of course, the same. Kasi nga, they were able to reach this level. Kaya nga, they have the same efficacy. But, sino ang mas potent? The question of potency naman tayo. Sino ang mas potent? Mas potent si A. Kasi nga, at 5 mg dose, you're able to reach this level. How about si B? Sino ang mas potent? Si A or si B? Si A pa rin. Kasi nga si B, kailangan mo pa ng 10 mg bago ma-reach mo to ang level na ito. How about letter C? Kailangan mo pa ng mas 15 mg before you reach the maximum efficacy. Kuha? So therefore, who is more potent? A, B, or C? It's gonna be A. Sino ang pinakamababa ang potency? It's gonna be letter C. Again ha, erase yung example na ako kanina ha. Ganito na example natin. Review natin again. Very sorry. Sige, review again. Last. Para hindi ma-confuse. For example, this table. Nagbigay ako ng 5 mg. Dito, 10 mg. Dito, 15 mg. But they were able to reach this level. So therefore, all of them reach a maximal efficacy. So all of them has the same efficacy. But when we talk about potency, the amount of drugs needed to produce a given effect. So si A binigay ko lang at 5 mg, si B binigay ko lang at 10 mg, si C binigay ko lang at 15 mg. But take note, si A binigay ko lang at 5 mg, but it will able to reach this efficacy level. Si B binigay ko at 10 at this level. Si C na-reach niya rin dito. Pero si C, kailangan mo pa ng 15 mg before you reach this effect. Compared to A, na kahit nagbigay ka lang ng 5 mg, na-reach mo na ang maximal effect. So therefore, again, sino mas potent? It's gonna be A. Sino ang less potent? It's gonna be letter C. Very good. I guess that ends our basic principle ng ating pharmacology. Very basic lang talaga yun, guys. What is really important is to understand those basic principles. Actually, sobrang dami pa yung mga basic principle na yan. So, imagine pharmacology, sobrang hirap. Maraming mga diagrams, maraming mga principles na dapat intindihin. So, kudos sa ating mga pharmacists. Right now, we will be discussing the most common toxins and acute poisons. There are so many toxins, there are so many acute poisons, no? I have encountered a lot of mga patients sa hospital when I have my PGI shift sa SPMC. As in, they have their internal medicine, have a toxicology department. Not all hospital have toxicology departments. Again, not all hospital. So that's why nire-refer agad nila sa SPMC on proper management. Kasi nga, for example, yung mga sakit or mga drug or mga poisons na kailangan ng mga antidote, sometimes not present on the other hospital, only present in your SPMC. Sometimes nga, nasa Manila pa, pinapadala pa nila and all. That's why that's why there must be a proper referral of this patient sa mga hospital. Kasi nga, not all will have what do you call this one? A proper management for the patient na hindi nila kayang i-manage ang ganitong uri ng patients. So first, we have your cyanide. Your cyanide will bind avidly to the iron in your ferric state and inactivates your iron-containing enzyme. So please take note, cyanide binds avidly to your iron in the ferric state, therefore it will inactivate your iron-containing enzyme. And this can cause now the inhibition of your electrons transport cell death predominant in your CNS. Prevents cellular respiration and ATP formation. So because remember, your ETC is important in the production of your oxygen in the body. So without this one, if this is being inhibited by your ETC, therefore, you will have a low level of your ATP. No, sorry, not oxygen, but energy, your ATP. So that's why, again, your cyanide here will inactivate this enzyme, inactivates your cytochrome oxidase. So therefore, remember your ETC, it is essential for the production of your ATP or your energy. So inactivates mitochondrial oxidative phosphorylation, inhibits cellular separation. Therefore, since we do not have now your oxidative phosphorylation, your body will compensate kasi nga kulang tayo ng energy, it will yield into an aerobic. From aerobic, nagiging anaerobic na kasi nga this process is an aerobic, this needs oxygen. But because it is being inactivated, an enzyme here is being inactivated, therefore we cannot proceed with an aerobic metabolism. We will go with an anaerobic metabolism. And remember, in an anaerobic metabolism, it will lead to the formation of this byproduct, lactic acid. Kaya nagkakaroon tayo ng lactic acidosis. Kaya nagkakaroon tayo ng metabolic acidosis. Kaya ang patient natin nagiging metabolic acidotic. So these are the common symptoms of our patient: headache, nausea, vomiting, dizziness, rapid heart rate, and symptoms of longer exposures, usually unconsciousness, convulsion, respiratory failure, coma, or even death. So what would be our treatment of choice for our patient with cyanide? Again, we have this cyanide antidote package. So your cyanide antidote package is actually a kit components, and meron siyang specific na mga tawag dito, have a specific mode of action. Different kit components, please take note of this one. We have your amyl nitrate, we have your sodium nitrite, your sodium thiosulfate. Again, your amyl nitrite and your sodium nitrite. The purpose of this one, this is actually methemoglobin inducers. Your methemoglobin reversibly binds now with cyanide to form now your cyan-methemoglobin. So again, this will automatically cause now the attachment to your cyanide, causing your cyanomethemoglobin. Your sodium thiosulfate, on the other hand, will help to convert cyanide to thiocyanate, which is excreted renally. Next, we have your carbon monoxide. Again, you're familiar with this one. I already discussed this one sa ating hematology dati on my lecture video. This decreased oxygen transport, tissue hypoxia, and disrupts oxygen transport. Because remember, your carbon monoxide, ano nga ang purpose ng carbon monoxide? Anong ginagawa ng carbon monoxide sa ating red blood cells or ating hemoglobin? Take note, your carboxyhemoglobin brought about by your carbon monoxide results from the combination of a carbon monoxide with the heme iron. And again, take note, affinity of your carbon monoxide for hemoglobin is 240 times on that of your oxygen. Instead na mag-a-attach yung oxygen, hindi na makaka-attach kasi nga yung carbon monoxide has higher affinity. This 240 times than of your oxygen. This is a silent killer because it is an odorless, colorless gas, and victims may quickly become hypoxic. That's why it gives now our patient a blood very cherry red color, which is sometimes imparted to the skin. So that's why makita natin ng patient natin cherry red in color. Treatment involves a removal of the patient from the carbon monoxide source and administration of 100% oxygen. So, matawag ito, binibigyan natin agad-agad ng 100% oxygen, administration of your 100% oxygen. Sources, exogenous carbon monoxide. Again, what will be our sources for your carbon monoxide poisoning? Exogenous carbon monoxide is derived from your exhaust of your automobiles, yung tobacco smoke, and from the industrial pollutants such as your coal, gas, and charcoal burning. Again, exposure to carbon monoxide could be coincidental, accidental, or intentional. That is why there must be a proper investigation to take note kung intentional ba yun, or suicidal ba yun, or accidental, or pwedeng co-accidental. And many deaths from house fires are the result of inhaling smoke fumes or carbon monoxide. Again, ang reason kahit namamatay tayo sa house fire is not really on the fire itself, but rather the inhaling smoke of fumes or your carbon dioxide. So again, I already shared with you this one, yung story sa strategic na tragedy na nangyari sa family ni Carol Banawa. She's a singer. I don't know if kilala niyo pa to. Again, na-share ko na to sa hematology. Yung Carol Banawa remembers her brother on his 20th death. Kasi yung in 2003, tragic incident claimed the life of Carl Banawa's brother and another family member. That parang natutulog sila, were sleeping in a parked car which lead to a carbon monoxide poisoning. Her father was able to survive but become paralyzed, which lead to his eventual death in 2012. So again, no, please take note, huwag kayong matutulog sa parked car na nakaka-on ng sakyanan kasi naka-on yung engine, or baka we don't know, kahit hindi naka-on yung engine, there's a leakage, then it can still lead to carbon monoxide poisoning. So that's why kung matulog sa car, make sure that open yung mga windows. Kaya ayaw din natin matutulog, no, sa car kasi pag open, baka nakawan din tayo. So please take note, wag na lang matulog sa car. Okay? So again, this is very, very tragic. So again, cherry red appearance of the carbon monoxide poison. So kaya namumulang-mula talaga sila. So again, your carbon monoxide poisoning, build-up of your carbon monoxide in the blood. Carbon monoxide produced from a burning of fuels and contained in carbon, charcoal, sa oils, wood, and even in the kerosene. And silent killer sila. Can cause odorless, tasteless, colorless. Kasi nga, silent killer sila kasi nga odorless, tasteless, and colorless. So, we put our patient in a chamber that will produce 100% oxygenation. Ito yung tinatawag natin yung chamber na nilalagay namin yung patient dyan. Tapos, there will be 100% oxygenation, administration of 100% oxygenation. Next, we have your different alcohols and glycols. So please take note of these different alcohols. We have your ethanol, which is present in your beverage, cough and cold medication, and even your mouthwash. Your isopropyl alcohol, which is now your rubbing alcohol, but also present in mouthwash or different solvents. And your methanol, which is present in the paint thinner, sterno, photocopier fluid, windshields, washing fluids, and your shellacs. So your ethanol, again, this is the most common drug of abuse, metabolized by your alcohol dehydrogenase to acetaldehyde or your acetyl-CoA. So please take note of the fetal dose, 300 to 400 ml pure or 600 to 800 ml of 100 proof whiskey consumed in less than 1 hour. So again, please do not consume this amount of drug. Take note, fetal dose na ito ha, fetal dose. If you drink a pure amount of 300 to 400, that is already fatal dose. Remember those nakikita natin sa Facebook na yung dinidrink, naglalagay sila ng pera, kung mainom mo yan siya, may certain amount ka, parang patoxic ng patoxic, pataas ng pataas, pa-increase ng toxicity ng ethanol na nilalagay nila, yung halo-halo na whiskey, kahit ano na nilalagay nila, and then iniinom nila in less than 1 hour. Take note, it can lead to fatal dose. Kaya nga, yung iba, iniinom nila, parang inuubos nila agad-agad. Diyos ko Lord. And they do not know the toxic effect that it can cause, no? Less than 1 hour lang. With this amount, can cause a fatal dose. And remember, your ethanol acts as a sedative, hypnotic, and depresses your CNS irregularly. It will cause decreased inhibitions in coordination, blurred vision, slurred speech, stupor, coma, seizure, and even death. Again, your ethanol acts as a sedative, hypnotic, and it will depress your CNS irregularly in descending order from the cortex to your medulla. Your methanol, this is a wood alcohol, 60 to 250 ml, as little as 15 ml, has caused death. It can metabolize by alcohol dehydrogenase to formaldehyde and formic acid. So that's why, no? Tingnan nyo, alcohol dehydrogenase will form into formaldehyde. Again, this is your formalin, your formic acid. That can cause toxicity, ocular, even in the eyes. Ethylene glycol, used in car radiator and antifreeze and coolant, metabolized to glycoaldehyde, glycolic acid, and glycosilic acid, can cause anuria and necrosis. And in terms of measurement, this one, you are using your HPLC measurement. This is just a specialized machine, not just for ethylene glycol, but also for other different alcohols. So, please take note of this diagram. Tingnan nyo. Your ethanol, yung color green na yan, indicates a relatively safer molecule. Yung may mga pula dyan, that's actually a toxic metabolite. Yung formic acid, yung formaldehyde, yung glycolic acid. So please take note of this reaction ha. Your ethanol becomes acetaldehyde by the action of your alcohol dehydrogenase. Your acetaldehyde by the action of your aldehyde dehydrogenase becomes your acetic acid, then converted into acetyl-CoA. Your methanol, on the other hand, same alcohol dehydrogenase to form your formaldehyde. By the action of your formaldehyde dehydrogenase, it becomes your formic acid. But take note, formic acid and formaldehyde is very toxic. For ethylene glycol, the same enzymes, alcohol dehydrogenase, until such time that it becomes your glycolic acid, and it still be converted towards becoming your oxalic acid. And these two, glycolic acid and your oxalic acid, are toxic metabolite. How about your isopropyl alcohol? Metabolized to acetone, carbon dioxide, and water. Fatal dose, 250 ml. And again, your CNS depressant and your GC for your measurement. So please take note ha. Isopropyl alcohol, yung mga alcohols and glycols natin are CNS depressants. So again, you learned also in your discussion, I believe ako nag-discuss nito sa inyo sa yung first sem nung CC1 ninyo, yung alcohols and glycols. So please take note, diba? To measure our alcohols and glycols, if there is toxicity, then we will check for the osmolar gap of our patient. So this is the formula, the measured osmolality minus your plasma osmolality, and you use this formula. Again, if the osmolar gap is greater than 10, it will suggest that the diagnosis of alcohol poisoning. Again, we use your osmolar gap to detect the presence of alcohol poisoning. So measured osmolality, usually yung measured osmolality, it is already given sa, for example, sa mga machines, derivative na usually given na yan, minus your plasma osmolality, and this will be the formula of your plasma osmolality. Okay? Osmolar gap is equal to measured osmolality minus plasma osmolality. Different alcohol poisoning type, we have your isopropyl, methanol, ethylene glycol, and ethanol. Ito yung discuss natin. And these are the clinical clue. Masasabi natin na, isopropyl alcohol siya, normal acid-base equilibrium, hypersomnolent or coma. So, usually, nag-undergo ng coma. Actually, hindi na naman isopropyl ang undergo ng coma. Almost all of this one, pag sobrang taas na ng dose. Methanol, again, take note methanol, vision abnormalities, and abdominal pain. Ethylene glycol, again, ethylene glycol, more of kidney injury. Take note of that ha. I will give you some cases na baka kidney problem pa lang ang presentation niya. So think of ethylene glycol. Pag methanol, vision abnormalities. Ethanol, ketoacidosis. Again, ketoacidosis. So our treatment, isopropyl alcohol, mild, IV fluids lang, and gastric lavage. Ano yung gastric lavage? Tinitake out natin kung ano yung nasa loob ng tiyan niya, hinuhugasan natin, and pinapalabas natin. Yung methanol natin, we give your fomepizole. This is your drug of choice for methanol poisoning, and ethylene glycol, also fomepizole. But again, they will undergo hemodialysis for both methanol and ethanol glycol because of kidney problems. Now we have also your different toxic elements in the body. We have your arsenic and your mercury. For your arsenic, this is present in your ant poisons, rodenticides, herbicides, weed killers, insecticides. No? Most importantly, when you take note of arsenic, think about the reversible interaction with multiple enzyme sulfhydryl groups. So again, because of the interactions sa ating different enzyme sulf groups. That's the most important thing for you to remember that. For mercury, again, this is very important. Mercury can pass through the blood-brain barrier. So, mababypass niya yung blood-brain barrier and can accumulate in your CNS. We have this most important, yung congenital Minamata disease. Please take note on this one. Yung congenital Minamata disease, stigmata of your cerebral palsy. So, you will learn about this later on. Yung acrodynia, pink disease, or your Fur-Swift disease, or your Fur syndrome, this is primarily in the children. There is a pink discoloration of your hands, feet, and your feet. There's also irritability and your photophobia and your polyneuritis. Again, when I say acrodynia, there's a pink discoloration of the hands and feet, irritability, photophobia, and your polyneuritis. Ito yung sinasabi natin na Minamata disease. Yung Minamata disease is actually your methyl mercury poisoning that occurs in the human who ingested your fish and shellfish contaminated by your methyl mercury discharged in the wastewater from a chemical plant. This is actually very common sa history ito sa Japan, from Japan. So again, Minamata disease, this is a poisoning disease that the nervous system, mainly your central nervous system, which is damaged by your methyl mercury. It is a established disease that the disease differs from your inorganic mercury poisoning, which damage your kidneys, etc., etc. And it's also confirmed that it damages the organs other than the nervous system. Kaya nagkakaroon ng CP or cerebral palsy yung mga patient natin. Kaya nga yung mga mothers na sobrang nabuntis sila, and then they got pregnant, and then they have high levels of your mercury, and then they can lead to a cerebral palsy to the newborns patient, toxic effect to the newborns. So again, please take note, Minamata mercury. You're also done with this one, your iron and your lead. Lead naman nun, lead, sorry. Your iron, we have your hemosiderosis, increased deposition of your iron in the tissues. You also have your hemochromatosis, excess iron, induces tissue damage, and vomiting will be the early manifestation. You also have your severe gastroenteritis, melena, kasi nga, blocking, di ba, your iron, pag nagtitake ka ng masyadong maraming iron, it will cause a darkening of your stool, abdominal pain, and your hematemesis. Your lead is by the inhalation or ingestion, still toxic effects in the CNS and your PNS. Then stored in the bones can lead to lead encephalopathy, peripheral neuropathy, and nephrosis or anemia. So this is now the diagram of how you see a gross examination of your hematochromatosis. This is now your healthy liver and the patients with iron overload in the liver. So the last part will be your organophosphates and your carbamates. Now we have your insecticides, pesticides. So please take note of this one. This is very important. Your organophosphates is usually present in insecticides and pesticides. This can lead to the inhibition of your acetylcholinesterase. This will lead to neurotoxicity, cranial nerve palsies, proximal limb weakness, and respiratory paralysis. So again, take note inhibit your acetylcholinesterase. So ano nangyayari? Again, your organophosphate is present in different insecticides or pesticides or industrial chemicals. So once you are being exposed with this one, what will happen? Your organophosphates are acetylcholinesterase inhibitor. So therefore, once it inhibits your acetylcholinesterase, it will increase now your acetylcholine in your synaptic cleft. So therefore, your acetylcholinesterase receptors will be overstimulated, causing now the signs and symptoms of your organophosphate. So again, review natin. This is your presynaptic neuron, this is your synapse, and this is your postsynaptic neuron. Your presynaptic neuron, with the stimulation, it will release your acetylcholine. Yung blue na yan, your acetylcholine. Yung acetylcholine natin, mag-a-attach sa receptor. Ito yung acetylcholine receptor, yung MNN. This is your muscarinic and nicotinic receptor na nasa ating postsynaptic neuron. Meron tayong acetylcholinesterase. The function of your acetylcholinesterase is to inhibit now your acetylcholine. Kasi nga, kung hindi naman kailangan ng acetylcholine, inihinhibit na yan ng ating cholinesterase. Kaya tinatawag na cholinesterase, an enzyme that will degrade your acetylcholine. So therefore, because of the presence of your organophosphate is an acetylcholinesterase inhibitor. Inihinhibit niya ang ating acetylcholinesterase inhibitor. So therefore, magsistay yung acetylcholine dito because there will no product or substance that will inhibit their action. So therefore, there will be overstimulation of your receptor. So because of that overstimulation of your acetylcholine receptors, it will now cause the different signs and symptoms of your organophosphate poisoning. I hope that is clear. Okay, review muna natin again. Mechanism of action, organophosphate, blocks the acetylcholinesterase enzyme, tataas yung acetylcholine level, magkakross ng increased cholinergic activity. And these are now the symptoms. Pag muscarinic, lahat basa. Salivation, lacrimation, urination, diarrhea, GI, and vomiting. No? Very easy to remember. Lahat ng basa, that's actually a muscarinic in nature. Nicotinic naman, there is fasciculation, weakness, hypertension, tachycardia, paralysis, and CNS symptoms, restlessness, headache, slurred speech, ataxia, and convulsion. So please take note of these symptoms. How do we manage? The most important part here is ang antidotes natin. Ito tayo pinaka-importante, yung atropine. Yung atropine natin is a competitive antagonist of your acetylcholine. So antagonist siya, competitive antagonist ng ating acetylcholine. So that will be your atropine. Or we give oxime, your pralidoxime, which will replenish now your acetylcholinesterase. Diba? Ini-inhibit sila ng ating organophosphate. But because of pralidoxime, nire-regenerate natin yung acetylcholinesterase. So, two ways ang ating management for your organophosphate poisoning. Pwedeng magbigay tayo ng competitive inhibitor ng ating acetylcholinesterase or competitive antagonist, not inhibitor again, competitive antagonist of your acetylcholine, atropine, and your pralidoxime, which will replenish your acetylcholinesterase. Okay? Please take note of these two drugs or antidotes. Excuse me. And lastly, we have your general management or history. So that is already the plus part na lang ito. So how do doctors manage our patient? What will be the general management for this one? Tapos na tayo sa acute poisons and toxins. Na-discussan natin yung pinaka-importante lang ng mga drugs and toxins, no? But this time, general management naman tayo. So how do doctors treat our patient? How do we manage our patient? Of course, first and foremost, these are the most important things na we need to ask our patient. Applies to any episode of your poisoning. What? Ano yung nainom niya? If we are talking about poisoning, you think of, first, what is a drug? That is why kung wala na yung patient na unconscious ang patient namin, of course, you have to investigate to elicit within the area na natagpuan ng patient. Ano bang, mayroon ba siyang na-take? Meron bang bottle? Meron ba siyang ininom? That's very important to take note of that agent. Because remember, different substances, different toxin substances will have different antidote. If we give just a normal antidote, then our patient will not survive. We have to be very specific kasi nga, your antidote is very specific to certain receptors. So, therefore, we have to take note of what those drugs that will have a specific effect on that matter. So, take note. Ano yun? Anong binibigay? Anong nainom ng patient? How much? Because that will also matter. Kung sobrang dami ba? Or maliit lang? Or katamtaman lang? Or very little dose na. So, we have to be check on that. When? Kailan niya nainom to? Kahapon pa ba to? Kailan pa? Ngayon ba? Bago lang? What else? Meron bang kasamang ininom? Aside from the drug, nakainom pa siya ng alcohol, nakainom pa siya ng ganito, and why? And why? The reason is, bakit siya uminom ng ganyang substance, toxic substances? Because remember, if the patient recovered na ang patient, remember, we just not treat our patient because of drugs. It should include emotional aspect, psychological aspect, because there might be a reason why ininom ito ng patient. It might be problematic, financial problem, love problem, whatsoever, etc. That's why we have to prefer our patient for a psychological intervention. That should be part of the management. So, in another way of checking our patient, pag dumating na ang patient namin sa hospital, these are the most important thing to remember. Airway. Check namin, humihinga pa ba ang pasyente? Kung hindi na humihinga, pwede namin tubuhan, lagyan ng tubo para makahinga. Breathing. Meron pa bang respiration ng patient? Circulation. Ano, check natin ang circulation. Pale ba ang pasyente or there's still a good circulation? D, disability or GCS? So, Glasgow Coma Scale. So, please take note na lang on this one. You're still, hindi pa kami kayo med student. So, please take note. So, Glasgow Scale, check namin ang level of consciousness ng patient dito. DFG, don't ever forget the glucose. So, check natin ang glucose level ng patient. Kasi nga, baka naging unconscious ang patient kasi nga, mababa ang glucose level. And then, get a set of basic observations. So, you have to observe your patient. Use all your senses, search for the clues, track for marks, the pupil size, feel the temperature, the sweating, the smell, the alcohol. So this will give us a clue. This will help us, no? Most importantly for those na mga patient na wala jud kasao, hindi alam ng kanilang folks ano nangyari sa patient at they do not know about your patient. That's why we have to look for these possible clues. Lahat ng senses natin gagamitin natin. There's a possible marks. For example, dati ang patient namin nagbigti pala siya and now nagbigti again, pero ang another ginamit niya is nag-inom siya ng toxic substance, pero nakita namin may mga chalk marks na sa kanyang neck kasi nga previously pa and a week ago pa meron na siyang history of that. So with that, you already have a clue. Next, decreasing drug absorption. So gastric, so you have to decrease the drug absorption. For example, ininom niya, so mabilisan talaga dapat ang galaw. Gastric lavage. So lilinisan mo yung gastric area natin. Gagamit ka ng tube. And then, you wash it out and papalabasin natin para konting drugs na lang ang mga-absorb. Remember, kung ininom niyo yun, re-absorb yun sa kanyang katawan. And you can use your absorbents. You have your activated charcoal, usually within 1 hour of ingestion. And longer repeated doses and drugs that delay your gastric emptying. We have also different specific management option. Increasing drug elimination. So, if hindi natin makokontrol, kung masyadong marami na yung drug na na-absorb, then you do drug elimination. You can give alkaline diuresis for this is common, no? For aspirin patient, for those patient na who has aspirin poisoning, nagbibigay kami ng alkaline diuresis para ma-eliminate yung aspirin, or hemodialysis, nililinis na yung dugo para matanggal na yung aspirin. So, these are the most common, no? Meron kami mga patient dati, aspirin poisoning, ininom ng aspirin. So this is one way for us to eliminate these substances using increasing drug elimination. And you can give antagonizing effects of the poison. So these are the most common antagonizing or antidote that we give to your patient. If you have iron overload, we have your dysferoxamine. For opiates, we give naloxone. For paracetamol poisoning, we give N-acetylcysteine because they will have an antagonizing effects of the poison. So these are the most common na mga antagonizing or antidote for these different toxic substances. Pag may iron poisoning, opioid poisoning, paracetamol poisoning. I guess that ends our video lecture. It's quite very boring, no? Somehow very interesting man ang pharmacology, but very difficult somehow to understand. That's why, no, nasayangan ako bakit wala kayong pharmacology. Thank you everyone for listening. If you have your questions, please do not hesitate to PM me. We will have a quiz this Friday together with your gonads sa lesson ni Doc Ian. So, dalawang topics ang ating i-quiz this Friday. So, good luck with your comprehensive exam. This will cover the entire topics ng CC2, prelims, midterms, and finals. But of course, majority of the questions will be from the finals and few questions from midterms and prelims. So, good luck everyone. I guess this will be my last lecture video in your batch. In your batch, this will be my last lecture video. Thank you everyone. Thank you for the journey. Wow, journey talaga. I'm very happy in your journey as a medical student, medtech student. And thank you so much guys for the fun learning discussion. I hope that you learned something from my topics, but not just from my topics, but from the different life lessons that I shared to you. So I'm very proud of you. So padayon lang gihapon, laban lang para sa pangarap, and I am praying for your success in the internship and in your board exam someday, and in your life's career, whatever journey man ninyo i-pursue, whether to work as a medtech, to be part of the academe, or to proceed into medicine. I will be praying for everyone sa inyong success. There will be a perfect timing for everything. Isipin nyo lang, perfect timing for everything. Just wait for the right time, in His time. Thank you everyone. I'm very, very happy sa inyong tanan. God bless you and bye-bye. Thank you.